Hi, good afternoon, all. Welcome to the July 5th session of the Virtual Learning Collaborative entitled Trauma-Informed Approaches for Viral Hepatitis, made possible in partnership with the CDC Division of Viral Hepatitis. So my name is Zakia Grubbs, and I'm a manager on the hepatitis team, and I'm joined today with Mahelet Kebede, Senior Manager, Organizational Excellence at NASTAD, who will be presenting today. The format for today's session is as follows. We will start with a brief overview of the health equity for data key informant interviews that NASDAQ conducted. Then we will have a presentation by Mahelet, followed by a moderated discussion. So feel free to use the chat to introduce yourselves and your jurisdiction and for questions. Later this month on July 26th, we will have our last VLC session for this year, where we would discuss the fiscal year 2024 hepatitis policy look ahead with presentations and discussions led by Julio Contreras at NASTAD and Emily Hirio with the Washington Department of Health. All right, so thank you all for joining, and I am going to briefly discuss the presentation that myself and Isabel gave at CSTE late last month on elimination and health equity. So for the CSTE presentation, we really wanted to get an idea of how jurisdictions are implementing health equity in their work, specifically surveillance programs. So we asked around to about 10 folks from across the US, from different jurisdictions, from different levels of health, professional development, from different identities and such. So we asked some questions on defining health equity, what are the impacts of COVID-19 on advancing health equity, how can they advance health equity within their micro and macro environment, what are some ways that they are engaging the community in surveillance, are they able to implement using a trauma-informed lens? And also knowing that this topic is kind of heavy, what are some words of encouragement that they have for their fellow surveillance staff? So first, we wanted to get an idea of what health equity means to folks, seeing if there's a standardized definition for the jurisdiction that they work in, or how do they approach health equity in their work. So we got a ton of responses. Some of them are thinking about how can we ensure that everyone is counted in the data? How can we create equal opportunity, especially for groups that are underrepresented? Ensuring that qualitative work is included in surveillance. So that way you get an opportunity to center voices of the community and making sure that they are part of informing what local programming. Also, folks mentioned making sure that work is fair and making sure that they address the underlying social determinants of health. Also, we can't escape the impacts of COVID-19 on our work, especially in surveillance. So we wanted to see how jurisdictions were able to advance health equity under COVID and if these impacts were sustainable. So for example, a lot of jurisdictions mentioned that they were able to strengthen their informatics system, especially increasing completeness for race ethnicity. They also mentioned having increased opportunities to collaborate with other surveillance programs and ensuring that we're all using the same language and advancing health equity and how folks are referred to. And also more points to how they were able to disaggregate the data based on race, ethnicity, and other demographic factors. And a lot of jurisdictions said that these changes were in fact sustainable. We also wanted to know, in addition to just the work, how are we increasing health equity within our workforce, particularly increasing the representation of BIPOC, LGBTQIA+ folks, and also people who use drugs. A lot of folks mentioned that, government is not the most, open-minded place for increasing representation among these groups, especially with limitations surrounding education requirements for hiring, and noting that there are lots of ways and that they definitely can do better in ensuring that they have a diverse workforce. Some folks did mention that they were able to hire folks without degrees, and other folks with lived experience, and also noting how that they were able to increase the professional development of some of these folks with lived experience, ensuring that they have opportunities for advancement within the field, and have opportunities to move around and learn different parts of the programs as well. So we also asked like how folks are advancing health equity within their microenvironment, looking at the work that they do and some of the policies, especially in regards to hiring, and seeing where there's opportunities for improvement. Also, they mentioned talking about building partnerships with local organizations and community, and making sure that these partnerships are strategic and advancing health equity and for folks. And also mentioned some involvement in internal work groups, especially around health equity and how we can work towards increasing that within the health department. Macro environment was a little bit of a challenge for folks, especially being government employees and not being able to advocate or having limited ability to do so. So definitely ensuring that we work with our partnerships strategically, making sure that we facilitate spaces for those with lived experience, and making sure that providing information and data to partners who can move that forward. Also making, like I mentioned, making sure that working with partners and working with the community and providing data to support changes in policy and in programming. Okay, and we also asked like how folks are engaging the community in their surveillance process, from deciding what to collect and how to collect it, all the way to presenting the end result to communities. So I think some folks said they feel a little disconnected with working in the community, and thinking that there are a lot of ways that they can improve relationships and improve data collection and getting feedback from the community, learning what is useful to folks, what do they want to see in the data. We did get a lot of feedback from folks on how they are thinking of multiple ways of disseminating data to the community, through press releases, through radio, through social media, having visual and very easy to read data reports, so that way folks can engage with the data. So also we asked about implementing a trauma-informed lens, and a lot of folks did mention that they don't think that they can do that. They don't have the tools. So hopefully our presentation today will help folks with that, at least as a start. But folks mentioned using a person-first language, understanding and trying to really explain, especially using qualitative data, what is going on, feeling empathy about presenting the data as well, and using patient-first storytelling data to really get an idea of what's going on in the community, and not just presenting numbers, but presenting a full picture of what's going on. We had some words of encouragement from folks, just knowing that we can do better, and understanding that there's a lot that we can do to improve health equity in our community, but also understanding that we all take, we're trying to make as many changes as we can, and I guess to give ourselves a little bit of grace with that. And also, when we talk about health equity and trying to center voices of folks that have been marginalized, just understanding that we will be uncomfortable. There's a lot of uncomfortable conversations that will have to happen, and we just have to sit back and be part of that. And so, like I said, everyone has a role to play in health equity. And some self-care words of advice from folks, we want to make sure we take care of ourselves, and that way we can continue on this work without being burnt out. So we just had a couple of probing questions for folks, seeing if the data that we released and the data that we're collecting, does it tell a complete story of where the inequities lie? Are we describing who has power and who has resources and who don't? And also using, making sure the data is describing who is being placed intentionally at risk. So we had a couple of action items that we posed to the group at CSDE. We also want to post to the larger group here. Making sure that we find ways to address health equity internally, like if you have a health equity work group within your health department, joining that or creating one as well. Looking at ways to increase diversity among surveillance staff, with hiring, retention, and promotion, building relationships with the community, and not necessarily just relying on prevention programs for having those relationships, and making sure that we compensate folks for their time. I don't know, and take care of each other. I think that's something that we always have to make sure we do so we can stay in this work. And also, if there's anything that we can do at NASTAD, please let us know. And I think that is all that I have. If y'all have any questions, feel free to let us know. And I will turn it over to Mahelet, who will be talking to us about trauma-informed approaches. So thank you all for joining us today.
Good afternoon or good morning to you all. Thank you, Zakia, for providing that overview on the data that was collected through that survey. And also just want to say a thank you to the viral hepatitis team for inviting me on to share with you all today about the work I lead at NASTAD, which is around trauma-informed principles. So I'm going to go ahead and get these slides going. And when is that working? Okay, can you all see the slides in presentation mode now?
Yes.
Perfect. All right. And of course, I will not be able to see the chat while I slide share. So if I can just ask NASTAD staff to flag anything for me in the chat that I need to respond to, that would be super helpful. Right. So as Zakia mentioned, we're going to be talking a bit about trauma-informed approaches, specifically to the work that you all do and how it may apply and could be incorporated or implemented. And so I like to just share, like a quote or words of wisdom, etc., regarding trauma-informed approaches or just trauma when I present this material. And so the quote for today is from Resmaa Menakem, who is an author of a book about trauma, specifically trauma within the context of race, so racialized trauma. But the quote here, I think, applies to the work that you all do in viral hepatitis and really just more broadly within society. I think it applies. And so the quote is, trauma in a person decontextualized over time looks like personality. Trauma in a family decontextualized over time looks like family traits. Trauma in a people decontextualized over time looks like culture. And what I really appreciate about these words from Resmaa are that, people behave in a way for a specific reason, right? And if we don't understand what in their environment or the experiences they've had that have led them to behave in this way, to have certain perspectives on things, etc., then we're missing a really big, important piece of the puzzle for us to understand. So I just appreciate this, this reflection, if you will, because I think it reminds us to understand that people make the choices that they do, right, and engage in the behaviors that they do for a reason. And if we don't have an understanding of that reason, then we won't really appreciate why they behave in the ways that they do, or why they might think in the ways that they do. And I think that trauma-informed approaches and our understanding of trauma, which we'll be shifting a little into here, demystifies some of these behaviors and perspectives we might see so that we can better understand the folks that we work with, whether they are our peers and a part of the workforce, or whether it's the clients that we serve through the programs that we administer, right? And so just some terms here. We often use these terms, I think, I know I do, but we don't often have a shared understanding of what they are. So first, trauma. There are many definitions of trauma that exist. This is just the one that NASTAD has adopted and adapted for our TIA work. So trauma is broadly defined as experiences that produce intense emotional pain, fear, or distress, often resulting in long-term physiological and psychological consequences. Experiences of trauma, especially in childhood, can change a person's brain structure, contributing to long-term physical and behavioral health problems or issues. And so I want to delineate. I'm trying to be more conscious about doing this during trainings because I think folks often misunderstand. There is a traumatic event, right? And what makes something a traumatic event, which is different from the actual trauma itself, which happens as a result of that traumatic event. How you differentiate a traumatic experience from a non-traumatic experience is truly individualized, right? Or community level. I can experience something and Zakia can experience something. And depending on, who we are, the experiences that we have had that have led us to this moment, to me, something can be devastating, right? I receive it as devastating. And to Zakia, it can just be another day, right? It can be a walk in the park. It really just depends on that individual and on a community when we talk about community level trauma. Now, trauma informed is what we are inviting you all to do, right? It's an approach to administering services that you administer within your viral hepatitis programs, both on the care side, on the surveillance side, or on the prevention side and surveillance side, excuse me. I know that's what this group largely focuses on. To interacting with your colleagues or with the clients that you serve, that acknowledges that traumas may have occurred in the past in someone's life, or they could be occurring right now, right? And that those traumas can manifest physically, mentally, or behaviorally, right? So we want to be responsive to that, that trauma that can be happening or has happened in someone's life, but even if it happened in the past, it is manifesting still, right, in how they look at things, how they behave to this day. Now, TIC stands for Trauma-Informed Care, or TIC. I've heard some folks refer to it as. TIA is Trauma-Informed Approaches, or TIA. I've heard some folks refer to it as that. Trauma-informed care is one type of trauma-informed approach, right? You can have trauma-informed policies. You can have trauma-informed procedures, right? It's not just about the care between a provider and a patient. It's so much more broad than that. So that is why we at NASTAD have adopted the term trauma-informed approaches versus trauma-informed care. Also, our membership, by and large, are not individuals who provide direct care. So TIC doesn't always make sense for us. However, obviously, many of the folks in our membership work with direct service providers. And so it is still very important that we take into consideration trauma-informed care and that we learn and practice trauma-informed care. We just want to emphasize that that can be one tool in a really broad toolbox. And finally, healing center. This is the newest term that we have adopted and practice that we are working to adopt and train on. And the definition we're using is adopted from Dr. Sean Ginwright, who's one of the foremost thought leaders on healing-centered engagement. And how Dr. Ginwright defines this is non-clinical, strengths-based approaches that advance a holistic view of healing and recenters culture and identity as a central feature in well-being. And the reason we have adopted both a healing-centered approach along with a trauma-informed approach is because there are very fair criticisms of trauma-informed approaches that exist and that we have heard over the years. So in an effort to be responsive to that, and for those of you who maybe are not familiar with some of those criticisms, many folks, especially in community, feel like trauma is pathologized, and that is really just a fancy way of saying that it sounds very much like a diagnosis and has like a more negative connotation that comes along with it. And so ultimately what we want to do is acknowledge that trauma exists. We don't necessarily need to survey everyone. What we know, at least on the HIV side, I would have to brush up on my knowledge on the viral hep side. But at least on the HIV side is that people who are living with HIV disproportionately experience trauma when compared with adults who are not living with HIV. The research has shown us that time and time again. So it's less about figuring out what happens. Trauma, unlike diabetes, right? Just to pick on diabetes as an example, once you have diabetes, unfortunately, we have no cure for diabetes. It's something that you live with, you either self-manage or you have treatment that you receive in order to manage it. Trauma is something that you can heal from. It's not a lifelong diagnosis. Once you're traumatized, you're always going to be a traumatized individual. Yes, you would have experienced that traumatic experience. However, there are coping mechanisms, there are school tools, techniques, etc., that a person who has experienced trauma can incorporate and implement, and also heal from that experience, so that yes, they are a person who has experienced trauma. However, that doesn't make them a traumatized person for the rest of their life. And so this is why we are trying to incorporate more healing-centered practices. Also, at the end of the day, it can't hurt to healing center engage with people, right? As opposed to centering maybe more negative experiences that folks have had. Healing is a good thing, even for those of us who have not experienced significant trauma. So I just want to level set with that. And if folks have questions, I'm going to move through pretty quickly because I want to make sure we have time for questions and discussion. But if you have questions as we're going along, please feel free to drop them in the chat so we can make sure to get to them when we go through Q&A. Why is TIA essential to our work? For a few reasons. It allows you to understand an individual's experiences. We just talked a bit about that, right? The better we understand folks, the better care we can provide for them. And also the more we can empathize. And so shout out to the folks in the survey results that Zakia was sharing with us a few minutes ago that pointed out that incorporating empathy into their practice has worked pretty well. And that has been, a goal of theirs. Second, it helps healthcare providers engage their patients more effectively. So I think ultimately a lot of folks' goals within our field of work is to engage and retain folks in care. For folks who are on the care side, for those of you who are on the prevention side, you still want to make sure folks are engaging with the healthcare system and with your services, because that's how we can prevent them from potentially acquiring viral hepatitis. And ultimately, this is, I don't know how else to frame this. This always sounds gross to me, but because the bottom line is unfortunately something that many folks have to think about, it does help to reduce avoidable costs. And that is just the nature of the field that we work in, right? Especially for folks on the viral hepatitis side, resources are extremely limited. So any help you can get, I'm sure, always counts. So you get that effect from it as well. It is important to achieving health equity, right? Again, Zakia just shared some nuggets from us with us, I should say, about some of the health equity advice and suggestions, and just centering for the work that you all are doing, and really just bringing those folks whose voices have been pushed into the margins traditionally back into the fold, right? And into the center of what we're doing, because who better knows what they need to heal, right? Again, emphasizing the healing-centered engagement than themselves, right? Really just emphasizing autonomy of individuals and the self-determination that human beings possessed. Finally, TIA can potentially improve patient engagement, treatment adherence, and health outcomes. Again, circling back to what we said earlier about healthcare providers, it can help you all in achieving some of the goals that your program has, frankly. Next, I am going to move us into the heart of what we are talking about today, which is the 6 principles of trauma-informed approaches from the Substance Abuse and Mental Health Services Administration. So these 6 principles were developed back in 2014, and really what SAMHSA did with a panel of experts is to outline sort of strategies or principles, right, that were really sort of high level, no matter what field or discipline you're working in with, whether it be HIV or viral hepatitis, or whether it be viral hepatitis prevention or viral hepatitis care. What can be incorporated and practiced throughout, right? Whether it be in the practices that you engage in, the policies you have, the care for those of you, working with folks who provide direct care, the care that those individuals are providing or those agencies are providing. And so we are going to walk through these 6. I'm going to define what they mean, what they look like, and invite you all to consider some questions that will really allow you to zero in on whether or not you all are engaging in these or I should say, operationalizing these principles, because I would guess some of you are already doing them and maybe you don't realize that you're, taking a trauma-informed approach, or B, for those of you who are not, how you might want to consider doing so moving forward. So we are going to start with safety. What safety means is an environment in which staff and clients are physically and emotionally safe. Staff are prioritizing clients' sense of safety and what these things can look like, right? When obtaining information to do, for example, partner notification on the surveillance side, do you check in with an individual to see how they are feeling and if there's additional support they may need? So it can be a partner, maybe when working with folks who inject drugs, folks that they might be sharing needles with, like friends, etc. Next, do you allow individuals to define what safety means for them? That's not a question I personally have ever been asked by a provider. So I appreciate this because safety looks different for all of us. And when we say safety here, it's not just physical. Again, going back to emotional, psychological. And then finally, is there a way for individuals to provide anonymous feedback regarding their experience? This is really important, right? We talk about quality improvement oftentimes in our line of work. How do you know that you're doing good if you don't ask? That's essentially what that gets at. How do you know where you can be doing better, what your room for improvement is, without asking? And what's important about the anonymous is that folks who might be in fear of retaliation or just being treated differently don't have to worry about that when things are anonymous. Moving along, collaboration and mutuality. What this looks like. There's both a sense and actualization, important to delineate between those two, of collaboration between clients and staff. Staff across the agency hierarchy feel empowered in decision-making. There's a sense of understanding that everyone has a role and each role is important to achieve the stated goals of the agency and clients. What this can look like. So something you might want to consider, are clients given the opportunity to decide their treatment goals and given options on how to achieve those goals? So mind-blowing here. Maybe, I know that, only some of you work on the care side, but something that's mind-blowing, we talk about this often on the HIV side, like some people's goals are not to become virally suppressed or to treat viral hepatitis first. If they're unhoused, they might just want to be housed, right? They wouldn't even have anywhere to store these meds if they didn't have housing. And so it's really important to ensure that we're engaging in these conversations. Do clients have a meaningful role in planning and evaluating services? This kind of goes back to what we were talking about with safety. How do we know what clients want and need if they're not a part of our program planning conversations? And then evaluating those services. Again, how do we know the services that we're creating and implementing are any good without asking the folks who are on the receiving end of them? And then finally, do administrative and direct services staff have a role in planning evaluation, planning and evaluating services as well? So oftentimes what happens is folks in leadership positions are at the forefront. And then the folks who are, more so maybe on the implementation side, but don't necessarily have decision-making status, we don't get their feedback, right? And we don't incorporate them maybe until the end, but like we plan these entire programs without getting their input when really their input and their buy-in, frankly, are key to have at the offset. Moving along, trustworthiness and transparency. This means that an agency's operations and decisions are made transparently and with the goal of fostering a trusting relationship between staff and clients, as well as amongst the staff of different positionality. So it goes both ways, right? For us on the inside, I'm saying us as if I'm a part of the health department, looking out to our external partners in community, folks who are living with HIV, and then internal to the health departments, there's a hierarchy, right? Like we already addressed. What does the relationship look like just within the hierarchy? Is there transparency that exists? When decisions are they made unilaterally by those decision makers, right? Those positions in leadership, the people who are in positions of leadership, or are they made with folks all across the board, right? From folks who do more admin side of work, maybe provide direct services to folks who are more on the executive side. And so these are things to keep in mind, right? And then, the other thing to keep in mind here, when we say positionality, right, there are differences in social position and power, which shape identities and access in our society as a whole, whether that be we're talking about a work environment or more broadly. Do you explain why you are asking for specific information and what it will be used for? So this can be with partner services, maybe with services with folks' friends or community members. A lot of times we ask the same questions over and over of the clients that we work with, and it can be fatiguing, it can be triggering to them to answer them over and over, and they don't even realize why. And sometimes just sharing at that level and being transparent in that way can build trustworthiness between administrator or a service provider and that client. Are your organizational policies and procedures clearly stated and available for clients? So do they know what they're getting themselves into, right? Do they know what kind of organization they're engaging with, just so that they can be, right? Again, full transparency. I think of things like mandatory reporting here. Do folks know about mandatory reporting? Are there opportunities for those impacted by policies and procedures to provide feedback? So again, this goes back to what we were talking about earlier. Are the people who are on the receiving end also getting a chance to provide input upfront, or is their opinion or their perspective incorporated later in time once things have already been planned and carved out to a certain extent? When agency-wide decisions are being made, like budget cuts, for example, or even budget allocations, to be honest, are staff informed immediately? So this is something that a lot of times folks in decision-making positions might be frazzled because it's, oh my gosh, this budget is being cut. What are we going to do? I got to figure this out, et cetera, et cetera. And there might be some forgetfulness around communicating that to key folks. And the beauty of that level of transparency is maybe the folks that, you could have communicated that to would have helped to troubleshoot and come up with some solutions, as opposed to you operating in this sort of crisis mode by yourself. And maybe they would have come up with some stuff you didn't think about because their perspectives are different than yours, right? So there's that piece as well that is important. I'm just going to pause really quickly because I'm losing track of time. Zakia, am I doing okay with time?
About 10 minutes.
Okay. All right. So I am actually, if we've got 10 minutes to go, I'm doing okay on time, that means. I'm just going to pause. I know I'm zooming through really fast. Does anyone have any clarifying questions about what I have presented for these first three principles? So we've talked about peer support, collaboration and mutuality, and trustworthiness and transparency. Any clarifications needed so far? And feel free to come off mute if that's easier. Okay, hearing none, I will go ahead and go through the other three, and then we'll take some more time for questions. So empowerment, voice, and choice. What this looks like is that decisions are made with instead of for individuals. There's an inherent understanding for an individual's needs and circumstances, and staff are equipped to provide various options so that clients can make informed choices. So one thing you might be noticing from this definition is that there's a little bit of flavor of collaboration, mutuality. And I think that's one of the beauties of the principles, is that they're not mutually exclusive. They can overlap, and that's beautiful. That's great. It's not an issue at all. But that's kind of what we're getting at when we talk about collaboration, right, in the former principle. Provide staff with flexibility to make choices regarding their work as well. So is there flex about work starting time? What about alternative work schedules, right? We can go so on and so forth, remote work versus in person, but creating those opportunities so that folks have choices versus being like, this is your tour of duty, this is where you work, these are the hours, that we expect you to be available, et cetera, et cetera. Where is there wiggle room, or where can wiggle room be created? Questions to ask yourselves or reflect on. Are individuals asked what their goals for treatment are, how they would like their partners to be notified or friends, and what role, if any, they would feel comfortable playing in that notification? Are clients given an opportunity to provide input for programmatic or organizational decisions? Again, you're noticing probably some connectivity to the previous principles. And I see that there is a hand up. I'm going to go ahead and pause. I believe that's Odetta. Did you mean to do that?
I sure did.
Okay. And did I get your name right?
Yes, you did. Thank you so much. Am I okay to share my video too, or just my vocal? Uh-oh.
I think you are welcome to do whatever you would like.
Yes. I just want to say, let me turn you over here because I don't want you to think I'm not looking at you. I'm on my my other screen. Okay.
No worries.
So this is great information. So I'm actually, it's going to be kind of weird because I'm going to put on my, can you hear me?
Yes, I can hear you.
Okay. I'm going to put on my case manager hat on, is because that was one of the challenges that everything that you're saying is such great strategies on how to empower our community and to be advocates for themselves, to ask the appropriate questions they need to ask to make sure that it fits what they for their needs. But one of the challenges is that, we can enforce all this, but it depends on who their providers are, who their clinics are, how well they are trained. And I think it's something to look at. I'm sorry. Okay, there we go. It's something to look at in reference to how can we want to make sure they ask the right questions, but also include how to empower them to get the answers that they need. So I like we say empowerment, voice, and choice. And so, and then making sure that they have the support system behind them to challenge their providers, their physicians, the clinics, and say, okay, this is where I get my information from, and make sure they have a broad of support system. And so is that something that y'all can also include in your plan? Because I'm all for the empowerment. I'm all for, empowering our community, but some of them still don't have the ability or the vocabulary or the really just the ability to really advocate for themselves. And so what do you do in addition for those clients that may not have the ability to really advocate for themselves to get the adequate health services that they deserve? And I hope I know I'm all over the place, but this is so passionate when you say empowerment with our clients. It's like I always, this is a huge thing, because it's one thing being them having it, they're in our office, But once they get out into the real world, we're not there behind them. We're not there holding their hand because we're trying to empower them. And so we want to try to give them as much resources they need to make sure that they get what they need. And so I just wanted to kind of figure out, what is your plan in reference to adding that into your curriculum?
So this is a fantastic question. And I have a couple of thoughts and also let's put a pin in this and circle back as far as
okay. And I know it's a lot. It's a huge.
No, it's okay. It's totally okay. I'm really glad that you're asking and that this is something that's like resonating with you and that you're interested in. And Zakia, I might kick it over to you for the plan part, like the follow-up plan of incorporating this in the future. I will say two things and then invite Zakia if she would like to clarify for what the plan looks like moving forward to share what's upcoming. So one, to your point of this can at times be hard for you all to control because you're working with agencies that are the ones that are engaging with them more regularly and providing that direct care. So one thought or recommendation here, in some of the trainings we've done, we've been working with jurisdictions on actually incorporating trauma-informed approaches into the memorandums of understanding, contracts, whatever that form looks like or practice looks like within your respective jurisdiction as a requirement for those direct service agencies that actually engage with the clients. So I'll leave it up to you all of like, do you want to put a carrot in there or a stick or, what have you? But one way to ensure that this is happening on the provider level is being mindful of incorporating in whatever relationship you have and making it something that is clearly voiced and clearly stated as a priority for the health department. So that's one thought I have there. And then of course, in follow up to that, there's going to need to be some trainings, et cetera, which you can figure out and we could support you in figuring out what that looks like once we kind of cross that bridge. But you wouldn't want to require them just to do it and then be like, figure it out on your own. The second thing I'll say, I think empowerment, excuse me, is such an interesting term and concept. I used to think that empowerment was something that you can make someone feel or build in them. I now push back on the notion that you can empower individuals. I actually think that someone feeling empowered, that's a real thing, right? I don't question the concept. What I have begun to question is the ways in which people feel empowered. Oftentimes, what I have found is that when they exist in structures, right, and when they live in communities and societies, they engage with healthcare providers that allow them to make choices, right, that get out of their way. Instead of telling them, do this, this is how you should do it, this is where you should be, etc. Instead, they frame their questions and the care that they're providing of, what would you like? What is most important to you, right? This is when we start seeing like the lines blurred between the principles. A client can feel empowered when they actually have certain choices, right, to make with their care. When they have certain choices to make when it comes to how they might be engaging with the health department. When they are asked for input as far as, hey, the viral hepatitis program is trying to create new services. What do you all think that they should look like? Has this worked well? Has that not worked well? So I think that by saying we want to hear your voice and here are choices that you have, naturally, it's going to yield to a more empowered individual. I don't know if that makes sense, but I see your hand is back up.
Yes, it is. I'm sorry. No, I totally agree with you. And I'm just fighting my little nose. Because I am the viral hepatitis prevention coordinator. So I'm here. My position is to really empower my partners with the local health department, CBOs, to really engage hepatitis C testing and to bring on potential providers to want to get free training within the state of Maryland to be able to treat hepatitis C. Right. And so they have so many barriers. So we're not even talking on the client and the patient's level, we're even talking on the provider's level where is their buy-in for them to even accept for clients that we're working with, or we, a community, for them to accept them. So I know I'm going so broad, but it really does trickle down. And so dealing with patients individually is also empowering them. So you're going to have kickback. You're going to have providers that don't believe you or think that their way is one way. And, it's to continue to encourage them to, you have a voice. And if this provider does not work for you, to find another provider. But we all know hepatitis C, you have no money, and it's very limited providers that can do treatment, right? And HIV has a huge funding. And so that's, that's one kind of piggyback on. I totally agree with you. Like, we want to empower our community, but it goes even higher when it comes to providers that are so still just biased to hepatitis C and treatment, where they still want to go against our clients we're trying to empower. I hope I'm making sense too, but I totally agree with you. And I think that we have to look in a broader aspect. But the broader you look at it, the more complex it gets. I know, trust me, I know. I've been in HIV, I've been in all. The broader you get, here I go, the broader you get, is very complex, but we have to be very, try to deal with it on everybody's different levels. And so I think that, your presentation was very amazing, because this is the issue when it comes to inequality of health in all aspects, because they're not informed, or they think they're not informed, or the system makes them feel like they're not informed. So
absolutely.
I just want to say that. Thank you for listening.
Yeah.
I appreciate that.
Absolutely. And I'm zooming through these very lofty concepts and principles. And, I'm giving you some questions here and saying, I invite you to consider them and, think about them with, the rest of the folks on your team. And frankly, I am very much so oversimplifying what is essentially an overall culture shift in how we provide prevention services, care services, treatment services, etc. And so I just want to acknowledge that the changes we're talking about here, right? Me saying ask folks, what they want their treatment plan to look like. That's a simple question to ask. It is not a simple process at all to actually have everyone implementing them and then, asking that question and then implementing all of the changes that would have to happen as a result of, doing that. And so I just want to acknowledge that this is not, I'm not going to lie to you all, this is not necessarily easy work, and it's not necessarily fast work. I do want to be transparent about that. And so some of the things you're grappling with, I love that you're even thinking about them. And I think your mind is starting to, spin down into this, okay, what comes next? And then, and that's great. That I think that you're on the right track. Naturally, what I hope when people hear and learn more about trauma-informed approaches or healing-centered engagement is that they start questioning things and start examining all of the things about their systems, their practices, their culture, where it's ooh, I don't know about that. We would have to address that, and just start sort of tracking what seems like areas that, would need improvement and tweaking. And then after you have a sense of that, sort of starting, figuring out where do we start, right? And we have some tools that you all can use, and I'll try to plug that in a minute. I'm going to move forward for the sake of time, but thank you so much for that. And I really think that your thinking is right on track, and you having more and more questions is a natural response to these really lofty concepts that I am oversimplifying for the sake of time. So jumping back in with peer support. Individuals who are a member of communities or who are members of communities seeking to be served by, the services that you provide as a health department are a part of the creation and implementation of programming. So similar to what we were just talking about, more admin, frontline staff being a part of decision-making or program planning from the jump. Also the folks that receive your services, right? Peer support individuals provide input into operations, assessing the progress of the program or the success of a program, and connecting with new clients to assist also in the emotional support and warm handoffs when, for the example that was given earlier, someone has acquired viral hepatitis, and then we got to transition them into care, right? Having someone who can relate to your experience makes all the difference, just for that emotional support piece. Do CAB is, Consumer Advisory Board or Client Advisory Board members have meaningful roles within the organization, including leading activities and providing input on decision-making, right? This is something for you all to consider. Are peers included as navigators on health teams that you have? So again, like we just talked about, someone now has acquired viral hepatitis. Is there someone who's living with viral hepatitis that can hold their hand through the process of engaging in viral hepatitis treatment? And then finally, is there space and is it encouraged for staff to engage in peer-to-peer support? So you all yourselves are dealing with a lot oftentimes when administering these. So just an example we were just talking about, right? Having somebody to troubleshoot some of the stuff that you had in mind. Do you have a support system? When you're working with a client or maybe an agency that's just been really challenging to work with, do you have folks that you can lean on and a space, right? Like a monthly meeting of viral hepatitis coordinators or the viral hepatitis team where you can support one another, because the workforce also needs support. Cultural, gender, and historical considerations. There is an organizational understanding of how systems of oppression impact individuals' experiences of engaging with systems, particularly in governmental and healthcare settings. So this is where all the isms come into play. Racism, sexism, homophobia, classism, transphobia, all of these things, right? Are we considering them, especially when we talk about the folks who are living with viral hepatitis and how these are oftentimes people who are already from communities who were marginalized, right? Just in general in our society, really ensuring that we're considering those social identities that they possess and the intersection of those identities. And we're making sure to address that while we provide them services and care and in how we set up our system and our structures of care. Things you can consider, do you ask clients what name they would like to be used during their medical visits or when engaging with the health department? And then do you actually use those names? Do you have general and neutral restrooms, or do your provider agencies have those available, your direct service agencies? How has racism impacted clients and staff? Are these even conversations that you all are having? Do you have timely and reliable access to translation services? Not everyone's first language is English, right? These are things for us to consider. Some additional considerations, I know we're at time, I'm doing a bad job of timekeeping now, is around resilience. So this is just something to keep in mind. When we talk about resilience, it's a set of factors or traits that an individual possesses for whatever reasons that protects them from the effects of that trauma. So maybe you and I both experienced trauma, like we were talking about earlier, Zakia and I, but Zakia is perfectly fine because she has these set of factors, right? Protective factors, and resilience is how we frame them. She has resilience in a way that I do not. And so resilience mitigates the impact of that trauma. And this is also something that we should consider, in particular, wanting to take a strengths-based approach, right? What components of resilience and factors of resilience do people that we work with possess? And how can we really build on those strengths when we engage with them in care or in services that we're providing? During client visits, are you asking how client is connected to their community? We know that social relationships are a really, really big protective factor. Does your health department have an effective, reliable, and patient-centered referral system? This goes back to the issue you had brought up earlier, right, Odetta, of like, I can only refer you to so many people because there's only so many people that actually provide viral hepatitis care, or providers that can administer that sort of service. And then finally, in addition to providing coping skills, do you ask clients about what coping skills they've used thus far to thrive and survive? And then when they respond to that, are we taking a harm reduction approach, right? And not shaming them for behaviors that are not traditionally deemed as healthy, if that's how they've coped. So I am over time, And I'm going to pause now to see if you all have any additional questions, and if we even have time for those questions, Zakia.
Oh, yes, we have like 5 minutes or so for questions, so feel free to ask Mahelet.
And I know that was a lot of information. Again, apologies all. I tried to give you all a good little appetizer and squeeze in a lot in a short time, and I'm sure you're processing. So even if you don't have any questions yet, if there's any reflections or aha moments you had, I would love to hear those from you as well.
Well, I guess if we don't have any questions from the group, I guess tying into some of from the interviews that I discussed earlier, some of the concerns from some of their surveillance staff about how they can implement trauma-informed approaches into surveillance, such as like when folks are doing like client interviews, to, I guess, on the more jurisdictional level of like actually analyzing the data, reporting out the data. So I guess at those different levels of surveillance, I know you mentioned specific examples about partner services, but I don't know anything else you wanted to mention for how folks can implement these.
Yeah, so Zakia, I think this is actually a good time to plug one of the tools that we developed. What I did not mention is that NASTAD has a trauma-informed approaches toolkit, which includes everything that I just presented on. Really important for me to mention. We will make sure that you all have that toolkit if we haven't already sent it to you. There is one tool on there that I will just highlight really quickly, and that is called the healing centered considerations for intake and assessments. And I think that there are some gems there, as well as a resource we have. I'm trying to pull this stuff up fast. Another resource we have around the 6 principles that I think can be incorporated when whether you are a person who's doing interviews in the field, investigation, some sort of like disease investigation type role, or for those of you who are analyzing data. I actually think I'd borrow from the examples that folks shared in your results about storytelling. So being sure to capture both quantitative and qualitative data, right? We do usually a decent job, I mean, as much as we can collect viral hepatitis data with the quantitative side, but we don't always do a good job in telling stories. So like, yes, someone might have acquired viral hepatitis, or yes, maybe someone was cured, but like, what's the story behind that? What was their experience, right, in engaging with treatment? What supports did they have that allowed them to get to the point where they were able to be treatment adherent and to complete, right, that treatment and that regimen, I should say. And so this is one tool. Again, it's included on our toolkit: healing-centered considerations for program intake and psychosocial assessments. So this might not be exactly what you're doing, but there's some really great gems in here, and I'll just highlight a few that I think can apply to those situations. So when conducting an interview, right, things that can prompts, right, that can help us in creating a narrative. Tell me a little bit about yourself so I can better serve you, right? Not just going to questions of like, you know, do you inject drugs? When's the last time you injected? Do you share needles? When did you acquire viral hepatitis, right? Like this is that healing centered engagement. Tell us about you as a whole human being. And what this does is we're not just asking it to go through the motions, but also the information that we get, we can now use that to check in with the person later on when we're engaging with them, right? Maybe we're checking in to make sure, have you been treatment adherent? I know that you said that time when we first spoke that your best friend Bobby you trust with anything, and you just feel like this is a non-judgmental listening ear you have from Bobby, do you think that you can talk to Bobby about reminding you to make sure you make it to your appointments, right? It gives you some stuff to kind of build off of in the future, or maybe not you specifically if you're the ones who's conducting the interviews, but maybe information that you can then share with your colleagues who might do some of that follow-up, right? Maybe that's your colleagues at a direct services agency or at the local health department, right? Things that you can put into their file and ways that we can follow up with them in the future. So that's just one specific example. And we will be sure to include the toolkit and follow up.
Well, yeah, thank you so much. I know we're at time, but I don't know, Mahala, if you have a second. But I just wanted to thank you so much, and thank you all for joining us today. I did put the link in for the Trauma-Informed Approaches Toolkit. We also recently released a new 340B toolkit, and I put that in the link. And thank you all so much. I guess if we have a second, we can, I think Odetta had her hand up, and I saw a comment in the chat from Kimby, so I guess we can address those, but I just wanted to thank folks in case folks have to hop off.
You know, I talk too much, girl. So
No
for
worries.
time, I'm gonna let the young lady, the other young lady, ask her question.
Yeah, I don't know, Kimby, if you wanted to come off mute, or I can read your thoughts.
Hi, this is not a fully fleshed out
No
idea,
worries.
but I feel like something that I have noticed a lot is folks saying that they use harm reduction approaches and thinking that, you know, and I put in the chat, thinking that like our program is harm reduction based because now we allow people who use drugs to actually be in the program. And it feels like such a huge challenge to get, you know, real harm reduction education out. And I guess it's also hard because it feels like it's not just something that you can teach in a webinar necessarily, right? It's like after having lots of conversations yeah, so I don't know, that was just my thought that I wanted to throw out there and see if maybe anyone had any brilliant ideas about how to make that, how to fix that.
I'm sorry, this is
Thank you
Odetta.
for the presentation too. It was wonderful.
I'm sorry, I just want to make sure I understand the question. Can the young lady repeat it real quick? 2.3 seconds. What was your challenge?
So I was just talking about how there's not a lot of harm reduction education within healthcare in general. And because it has become kind of like a popular buzzword, for lack of a better term, you know, there's a lot of programs that are sort of claiming it without actually even knowing what it is. And so I don't really have a question. It's more of a just.
Oh, you know what? I'm happy that you said that, and I don't want to overtalk anybody, Zakia and Mahelet. Oh God, I'm gonna mess your name up, Miss Kebede. Kebede. I'm sorry, I don't want to mess your name up. They always mess my name up. The only thing I could say, I used to be a substance abuse counselor back in Florida. And when it comes to public health, what I realized transitions from substance abuse to public health, there is a sense of a gap, right? Because public health is very broad. And then when we get into our fields, it's very specific we're focusing on. And so it's going to be challenging. And what I'm hearing, it seems like it's a little fab thing, like, oh, everything now is substance abuse because you probably get more funding for it, right? You can probably get more resources for it because you put the title in substance abuse. I don't know what your situation is, but the only thing that I could definitely recommend is definitely reach out to NASTAD, reach out to your resources, because they will at least give you the tools you need to at least be educated and want to bring on and educate your peers too, because you don't want to mistreat anybody. If you say you're doing substance abuse, you don't have the tools to deal with substance abuse, that's not good quality of service. And that's not gonna look good on your jurisdiction, on your program. I would say just educate yourself first and definitely reach out for resources so you can kind of trigger some thought process within your leadership for them, everybody has to be trained properly on how to deal with substance abuse clients. I mean, I don't want to speak for y'all too, but it's a different ball game in my experience. So I just wanted to share that with her. Okay. And I dropped the mic ahead.
Yeah, thank you, Odetta. Yeah, I think it's something that the organization and the staff have to internalize. It's not like a concept that only works from like 9 to 5. It's a concept that you have to fully embrace in all aspects of your work, in all aspects of your life. So that way, you know, when clients come to you, they feel comfortable. And so I know it's a complete mind shift, but it is necessary. And I know that there will be a lot of growing pains in getting an organization to have a harm reduction approach or a trauma-informed approach. But I don't know, it's just something that has to be done at all levels, and it just has to be like infused in the entire program. So I know that's easier said than done, but I don't know, that's my
Well, can I say something in response to that, Zakia? Just, I feel like you hit it right on the head, that it's like, it's something that you have to have this concept in all of your life, right? Like not just at work, it's with your friends, with your family, with yourself. And I feel like that's a hard thing to ask people to do in a work environment, is like, oh, well, you need to think about everything differently now. Even though I personally think it is, you know, the best way to think about stuff, but it's hard to convince people, you know what I mean? It's like, it's not just this clear set of say this when this happens, or I don't know. Yeah.
And I just want to say real quick for the young ladies talking, don't get discouraged. The fact that you're talking about it, you're passionate about it, lets us know that you know there's a need for it. You feel what I'm saying? And so I can't say nothing. There's a need for it. So do not, I'm very impressed, and I think we're all impressed that you're even talking about it, because you know that it's a need for it. And sometimes you got to do things outside our job title and get the information we need so we can be productive workers within our community. So I just want to give you a thumbs up for that. And thank you for asking the question. So I just want to give her a thumbs up. Because it's a lot. Because nobody want to deal with this particular population. So I just want to say thank you.
Thanks, Odetta.
Yeah, thank you all so much. And thank y'all for staying for a little while. This is definitely a conversation we'll try to have within all of our other topics we discuss, making sure it's integrated. So this won't be the last time we talk about this, but thank you all so much and enjoy the rest of your week.
Thank you. I really enjoyed it. Thank you.
Thank you.
I know, baby.